is the opposite. They are not, the missing food, they are eaten, not reported, and the phantom food, they are what? They are reported but not eaten. So these type of information or these type of data usually they are subjective. When I'm hearing that to the patient, I'm writing down his his symptoms. He is sometimes exaggerating. So we are having sometimes subjective data. The opposite here. Usually the biochemical data, these are numbers. These are very objective numbers. It provides specific information on the body status. When I am measuring, for example, the ferritin or the soluble transferrin receptors, it gives me a clear picture about how much iron I am having in my body. Can be used to assess the nutritional status of a large population or groups. Yes, when we are doing the screening for the school kids who are in thousands, so they can be used for large number of population for a different type of tests. Biochemical assessment, usually in nutritional assessment, we have laboratory methods include measurements of the nutrient itself. So I am measuring here vitamin D. I am measuring here vitamin A as an antioxidant. And sometimes I am not measuring the nutrient itself, but I am measuring other metabolites which can indicate the deficiency or sufficiency of this vitamin, for example. For example, B12, it is not recommended to be used to be tested directly in the serum. Instead of that, we have methyl malonalic acid as a metabolite related for B12 estimation, and it's considered the gold standard for measuring B12. Advantages, already we talked about the objectivity. It is very accurate, it is very correct, it is independent. It cannot be affected by other, in general I'm talking, it is not affected by other immunities. Okay, can detect early subclinical signs before somebody is having, when somebody goes to the laboratory to test, for example, the ferritin. He doesn't have any signs of iron deficiency anemia. He doesn't have any of these. But when he reached and he has done, for example, the ferritin and the hemoglobin and the MCQ, for example, list of tests, so the physician can tell him that you have a deficiency of iron. It has not fully developed clinically, but later on, if you will continue in this dietary pattern, so you will be having a clinical features and a clinical signs later on. So it gives me early picture about the things which will happen in the future. Can confirm the existence of abnormality, yes. Since the clinical features sometimes they take time to develop, so it can give me an early picture. Precision and accuracy, they are very accurate. If I have used the correct procedure, if I have chosen the test with high sensitivity and reliability, so it will give me, of course, a precise and correct result. Disadvantages, these are usually costly and specific. For example, if I do hemoglobin or complete blood count, it is very cheap. But when I am going to very specific tests, for example, soluble transferrin receptor, which is indicator of the iron status in our body, it's very expensive. When I am doing pyridoxine or pyridoxal phosphate, it is very, very, very expensive. When I am doing MMA, methyl malonic acid, usually these type of tests, they are very expensive. Time consuming, yes, but with the new, revolution in the equipment, in the medical equipment, now they are very fast and They can run batches of hundreds of samples at the same time. Sometimes it is difficult to collect sample, especially when you have from, from the stools, for example, especially for the kids. Sometimes from the spinal fluid, it is sometimes the specimen of the sample collection can be difficult. Choosing the biochemical assessment method, we said it can be direct. I can directly take a blood, measure the vitamin D. Sometimes, no, it doesn't work. I have to search for other metabolites which can give me a clearer picture about, here are the list of the things which can be measured directly, and some of the things which cannot be measured directly. For example, the hemoglobin, the hematocrits, it can give me a picture about, the iron or the type of anemia which I am having. Binding protein, retinol, binding protein. See, these are the things which can be measured indirectly or can give indication about something else. Urinary excretion, for example, calcium urinary excretion, iodine urinary excretion. This also can give a good picture about the urine or the calcium. Obtained non-invisibly. Now here, these are the ideal biomarkers. So based on these information, I have to be very selective. And here, I have to use my knowledge. I have to go back to the NCB. I have to use my knowledge. I have to use my communication with the physician, for example, or the laboratory assistant or lab technician. Also, critical thinking I have to use, because I have to see, okay, these are two tests. These are for the iron deficiency anemia. But this one is affected by infection, inflammation, and chronic conditions. But this one, it is not affected. So I have to read well. Here is my background, my education background, give me the strength to decide. So I have to use my critical thinking to choose the most relevant, the most reliable and sensitive test among all these. So we should obtain them invisibly, as long as can get sample very easy. So I have to go for it. Level should not overlap with healthy control. Some of the tests they doesn't have clear cut-off point. For example, the soluble transferrin receptor, which is very good indicator for iron, it doesn't have very clear. This is one of the limitations. It doesn't have a clear cut-off point. High sensitivity and specificity, I choose this one. Sometimes it's expensive, quick, easy, cost-effective, correlate to severity of the disease condition, biomarkers that can respond to the treatment. Okay, yes. Sometimes I'm using some of the tests for examining the deficiency and the depletion. For example, let us give an example: albumin and retinol binding protein. The retinol binding protein can be chosen for indication of malnutrition because it has shorter lifetime and limited storage in our body. Within hours, it can give you an indicator, but the albumin, it will take around 18 to 20 days to give you that result. So, but I started feeding this patient. So the retinol binding protein, which was good in the deficiency, is not good in the repletion status because it has short storage, so it will be filled directly with minimal feeding. In this case, so I will go for albumin instead of retinol binding protein. So we have two cases. We have to talk about the iron measurement and the calcium measurement. We should, here we will see the different tests in each one of them and how we will proceed, how we will be very selective. The serum ferritin, this is one of of the major storage form of the iron which is present in the body. It can be present in the spleen, the liver, and the bone marrow. It is very sensitive marker for iron deficiency anemia. When there is no any other complication, as long as I have, limited amount of iron in my body, in my stores. So when I do the test for ferritin, it will give me that there is deficiency in the iron in my body. Accessibility in a clinical setting, serum ferritin measurement is simple and widely available in case of there is no inflammation, no infection, no any chronic disease. Guides the treatment decision. When I go and the physician can see that I have deficiency in the storage of the iron and the ferritin number is very low, he will recommend either to go for tablets in the form of ferrous sulfate, ferrous fumarate, ferrous gluconate, or I should go for IV. So here it can give the physician the decision what type of the treatment that should be given to this patient. Disadvantage of the serum ferritin. Serum ferritin is acute phase reactant, means when I am having inflammation, when I am having infection, this type of the protein is increasing. And here, when the ferritin level increases in the case of the inflammation, here it masks the deficiency of the iron if it exists. So the correlation between the iron stored in the body and the ferritin reading in the case of inflammation, infection, and a chronic disease, now it does not exist. It does not exist. So some of the people, they recommend usually, when I look at the CRP, C-reactive protein, which is indicator of the inflammation, and it is above the normal level, so either they don't use the ferritin as indicator. Some of the scientists and schools, they have do like corrective measurements to minimize the effect of the inflammation. So here, sometimes it gives me false, normal, or even elevated number than normal when I am having iron deficiency. So the correlation between the two, between the ferritin and the iron store, now in the case of the inflammation, it does not exist. Limited severity reflection. Low ferritin level indicates early deficiency. In the early stages of the deficiency, the ferritin can give me a good number. But as the deficiency proceeds and gets more severe day by day, this correlation between the ferritin increase in number and the severity, now it does not exist. So this is another limitation, that it loses the correlation between the iron deficiency as the deficiency proceeds. Okay? Risk of misdiagnosis, relying solely, completely on the ferritin itself by its own is a wrong procedure, because it is affected by many things. It loses the correlation with the iron stores in case of severity of the condition. So I should take other tests in combination with the ferritin. So this will help me in the correct diagnosis. So here we have the transferrin, serum, iron, and total iron binding capacity. The transferrin is also another protein, is produced in the liver, beta globulin. That one was positive reactant, acute positive. This one is negative reactant. So it is also affected by by inflammation, but in different way. Serum iron and TI. Actually, usually the measurement of transferrin is not directly can be done, but it's usually done through the serum iron and the total iron binding capacity. So in case we have low serum iron, so what will happen to the total iron binding capacity? What will happen? Yes. It will increase. It will increase. And the transferrin saturation decrease till I can usually I can say that total iron binding capacity is like the magnetic. When the iron is very low, the magnetic power is increased to attract more iron. Okay? Transferrin saturation indicator, transferrin saturation ratio help to identify the iron deficiency. Usually, the transferrin saturation is calculated by the iron, the serum iron divided by the total iron binding capacity multiplied by 100. This will give me the transferrin saturation. So all the three, they are linked together. Serum iron divided by total iron binding capacity multiplied by 100. This will give me the transferrin saturation. Diagnostic values. Combined iron test accurately distinguish the iron deficiency, especially it comes from the iron deficiency which causes microcytopenia. Disadvantages, as we said, it can be affected by inflammation. Change between the tissue's iron depletion and anemia onset, sometimes remaining normal despite of the deficiency, which is giving me a wrong result. Total iron binding capacity specificity issue. There is, it is not, sometimes it is not very specific, but total iron is not completely specific because of the other serum protein also bind iron. Some of the other protein, other than transferrin, can bind iron. Albumin can bind iron, different type. Lactoferrin can bind iron. Series of proteins can bind iron. So this capacity for iron is shared with others, so it is not very specific. Need for complementary tests, so I cannot also depend solely on the transferrin. I have to take it with other tests, serum iron, total iron binding capacity, ferritin, all of them together can help me. Soluble transferrin receptor, SPRF, which is the most recent, the most valid, which is very sensitive. It does not affected by inflammation or infection or chronic disease. It is early indicator. As soon as the depletion or the deficiency in the iron appears, this number start to increase or decrease, increase. When I am having less iron in my body, the SRF increase because it's start like searching for something iron to capture it and to bring it to the stores. Reflects cellular iron demand. Okay? Concentration increase with the low iron availability, showing the body's iron need. Unaffected by inflammation, improved diagnostic accuracy. It's very accurate, it's very sensitive, but it is very expensive. Disadvantages, there is nothing 100% perfect, so it can be affected by inflammatory activity. Uncertainty about the cutoff point. It doesn't have a clear cutoff point, but it can be helpful in the comparison before and after. It gives me higher number before the intervention, and now the number is less after I have given IV of iron. Different assay methods sometimes affect the make controversy about So here we have a case study of iron deficiency chronic inflammation and condition. So let us see, it is, so in this case, we have a patient who has rheumatoid arthritis, hypertension, type 2 diabetes, fatty liver disease, and stage 3 chronic kidney disease. So he has inflammation, and he has also inflammation related to RA, rheumatoid arthritis, also inflammation related to type 2 diabetes. Also, he has a chronic disease. Okay? Impact of the chronic inflammation. Chronic inflammation from rheumatoid arthritis and kidney disease complicate the anemia diagnosis and management. Diagnostic challenges. Inflammation affect iron biomarkers like ferritin, making accurate iron status assessment difficult. Here, I have three conditions. I have inflammation, I have infection, I have also a chronic disease. This will make the interpretation of the ferritin, it's very different, very difficult and inaccurate. So here we have the symptoms. Fatigue progressed over 6 months, severely affecting the daily activities and quality. Shortness of breath with a minimal physical activity. When he is doing a little of the physical activity, his breath is very high and very short. Mental fogginess, decrease the cerebral oxygenation. Not much oxygen is carried to the brain. And also other thing can cause the fogginess is some of the cognition cells which related to the enzyme. These enzymes are metalloenzymes and they need iron for their activity. So they are also affected. Evaluation importance. Chronic illness and inflammation can mask the iron deficiency. Symptoms and history are vital for the diagnosis. So let us look at the laboratory findings. The hemoglobin is what class of anemia it is? 7.9. It is severe anemic. Severe anemic, less than 8. Less than 8. 8 till 9.9. Less than 8, it is severe anemic. From 8 till 9.9 is moderate. 10 till, if she is a woman, 12.5. This is mild. Above the 12.5, if she is a woman, it is normal. 13.8, it is normal for women. So here the hemoglobin, he or she, they are having severe anemia. Let us look at the hematocrit. Usually we multiply the hemoglobin by 3, we are getting the hematocrit. 7.9 multiplied by 3, it is around 24. MCV, the value of the RBCs is less than normal, it is usually 82. 82, okay? So here also we have abnormal MCV. MCH, what's MCH? MCH is the mean corpuscular hemoglobin. Hemoglobin. It can be calculated. It means how much hemoglobin inside each RBCs. So when I have the total number of hemoglobin divided by the number of the RBCs, I can know how much hemoglobin inside each of these cells. So MCH is calculated by the total hemoglobin divided by the number of the RBCs. Ferritin, which is 89, which looks normal, beautiful number between the 20 and 200. C-reactive protein, which is indicator of the inflammation, which is above the normal level, which is the cut-off point of 8. Here we have 1.8. So what we can see here? We can see here that the ferritin looks normal. it doesn't show any deficiency, but all clinical features and all the other tests can say that he is having iron deficiency anemia. From the anemia, from the hemoglobin number, from the MCV number, and also, so I have to go for other tests which can give me accurate results, because the ferritin in this case, it masks the iron deficiency and doesn't give a good picture. So ferritin and inflammation, ferritin is an antigen reactant, so it is the same thing. So already I have said this, need for alternative biomarkers to replace the ferritin. SRF, soluble transferrin receptor, can be a solution because it is a combination of SRF. When I want to calculate the iron stored in my body, I'm using a formula. I think it came out by 2002 by WHO, in which they have merged in that calculation. I think it is in the other slide. It is the SRF, the SRF here, the FR, is the soluble transferrin receptor and ferritin. They are combined in one formula, so it gives me a good result. So, accurate diagnosis, use of the FR, soluble transferrin receptor, plus the log of the ferritin index. This together can give me a good picture. IV iron supplementation, intravenous iron was chosen due to, in this case, we have not recommend the use of tablets. Instead of that, we have recommended IV. Why? Because, yes, a problem in the oral absorption in the chronic kidney disease and rheumatoid arthritis. So instead of giving tablets, we recommend IV instead. Clinical improvement. Patient shows reduced fatigue and improved cognitive function after treatment with increased hemoglobin level. Tailored treatment importance. Customized therapy highlights the limits of the ferritin alone and the benefits of additional biomarkers for anemia management. So we didn't depend on one. A collective of things has been added together to give me accurate result. And even from the condition, I have gone for one method of supplementation instead of that other because of the clinical scenario in this case.
With like oral iron, you take it like every day or every other day. With IV supplementation, how often would the patient have to go and get that administered?
IV supplementation?
Yeah.
See, if it depends here on the, for the kids, I think we have a limit. Till the age of 5, I think we are giving, I'm talking about the tablets, for example, here by kilograms, till 2.5 for each kilogram, 2.5 to 3, but in case, this is when we are suspected anemia, but in case of he is confirmed having iron deficiency anemia, we are going to higher number, which is 6, and we are keeping observing after 2 weeks, 4 weeks, 2 months. Okay, so if we didn't find after 3 months improvement in the case, so we have to find another way, or we have to go for another supplementation.
So I think she's asking, like, if you're getting it intravenously, if you go in, you get it intravenously, and that would last what, a couple weeks?
A couple of weeks, yes, a couple of weeks, 2 weeks, and we can re-measure again and see the situation how it goes.
So if it resolves, yeah.
Yeah, tablets and IV, they have different procedure. If we are sometimes we are giving prophylactic dose, so it is usually 2 milligram for each kilogram, 2 to 2.5. But in case confirmed, and no need to go directly for IV, we increase the dose to reach to around 6 milligram for each kilogram, and observing 2 weeks, 4 weeks, 2 months, so we can evaluate the procedure after.
Thank you.
So here is one of the my work in which we have, it is published in Public Health and Nutrition. It is iron deficiency, a risk factor for postpartum depression. What's so unique about this paper? Most of the previous papers or articles, they have done oleferitin, they have used MCV, they have used hemoglobin as indicator, but in this paper, we have used all of these plus the soluble transferrin receptor, which is not affected by, which is very sensitive, not affected by other, by inflammation or infection. Okay? So let us jump to the calcium. So the calcium, different story with the calcium. The calcium usually it is tightly regulated. And it is tightly regulated and maintained with a very short limit, very narrow limit. If we talk in milligram per deciliter, it is 8.5 to 10.5, which is very narrow. If we talk about millimole, it is 3.3, am I right? It's 3.3, because usually we are dealing with milligram per deciliter than millimole. So it is, I think it is 2.3 till 3.6, something like that. It's between that. This is the normal for the calcium. So it is, what I want to say that it is within this narrow range, very narrow range, it is maintained. How it is maintained? How it is maintained? When I am eating or not eating enough amount of calcium, suppose this is a lactating mother, okay? And she is not eating 1,200 milligrams of calcium every day. And for the whole 6-7 months, she is not doing this. She is taking around 700, 800. And when I take a blood sample and test the calcium, still I can see that it is in the normal range. Why and how? When the body has depletion in the calcium, there are 3 mechanisms. The first one, the body senses and the parathyroid increase. When the parathyroid increase, it will increase the absorption and the efficiency of the absorption in the small intestine. This is one. It will also make resorption of the calcium from the bone. Take calcium from the bone and put it in the blood. This is the second. And the third is salvation from the kidney. Salvation and putting back in the blood. So when I am measuring the calcium in the blood of this lactating mother who is not having enough amount of calcium, the intake is 700 or even 600. She is maybe starving, she is in a conflict area like what we are seeing in Gaza. So she is pregnant and she is not eating. She's not eating any calcium-rich food. So, but when I'm doing a test to examine the serum, the calcium serum, it is normal. So these are the 3 mechanisms. And also the vitamin D also increased because it is searched for the calcium because the calcium mobilized by vitamin D. So because of that, it is tightly regulated because of these mechanisms. But sometimes this hematostasis of the calcium collapse in some of the conditions, like pancreatitis or acute pancreatitis, because here there is in hyperparathyroidism, vitamin D vitaminosis. Some of the conditions, this balance is affected. But usually in a healthy person, it is tightly regulated. So asking for calcium, serum calcium, it is not a good option. And I have to search for other options. So alternative, I can go for bone mineral content. I said just now that the calcium is taken from the bone. So more holes will look empty without calcium. So when I am doing a test by the DEXA, for example, the DEXA, for example, can give me a T-score. The T-score can measure the bone density mineralization, which is, it do like a scanning in a particular parts or bones. For example, usually we use the femoral bone or neck, femoral neck, or the spine or lumbar vertebra. These are the two locations where usually indicates sometimes the rest. These are the most common parts which can be scanned by the DEXA. So it do like counting, mineralization count, and it divided by the area scan, it give me the bone mineralization density. Count divided by area scan, it can give me that, and this is what we call it the T-score. The T-score. The T-score above -1, this is normal. Above -1. Okay? -1 to -2.5 osteopenia. Less than -2.5 osteoporosis. So here when I have avoided the serum calcium because it doesn't give me a correct, I know it doesn't give me a correct figure about what's going on with my calcium. So instead I have done for the DEXA and I have done T-score test, and which was less than -2.5. So I can say that this patient has osteoporosis, which is an indication of the calcium deficiency in his body. Okay? So serum calcium fraction. Usually the serum calcium fraction, it is present in three things, the three compartments. First of all, a protein bound, which is biologically inactive. The ionized one, which is the inactive, which can move from tissue to the blood, from bone to the blood, and from the kidney back to the blood. This is the one, the ionized one. And the third one, which is the complex form of calcium, which usually complex with anions such as citrate and phosphate. It's also inactive. So the main target here when I'm doing serum calcium is the ionized one. Physiological role of ionized calcium is biologically active. Clinical significance of serum calcium. Altered serum calcium level indicates serious metabolic disorder. Usually it is not altered. If he is a normal person, doesn't have any complication, he doesn't have, for example, acute pancreatitis, no hyperparathyroidism or parathyroidism, he doesn't have any. This will look normal even if he is having deficiency. Okay? Hypocalcemia and hypercalcemia, increase or decrease in the calcium level, can arise sometimes in certain conditions, certain disease affecting the calcium absorption, resorption, and reabsorption. Urinary calcium reflects intake, while the serum calcium does not reflect intake. Okay? Urine calcium level respond more quickly to the dietary intake than the serum calcium level. Diet composition impact high protein. Low phosphate diet is increase the calcium excretion. Phosphate rich diet may reduce it. So I can say that the phosphate in the diet can mediate the calcium diuretic effect of the protein. Usually, a protein by itself, too much or higher amount of the protein can lead to escape of the calcium in the urine. But this relation is not always fixed. It can alter by the level of that phosphate. So if the level of phosphate in this food is high, okay, so it will mediate and it will reduce the escape of the calcium in the urine. And the opposite is correct. Means when I have higher amount of the protein and lower amount of the phosphorus, this will not help in salvating or putting back the calcium to the in the blood. Diurnal variation, yes, the secretion in the daytime is more than in the nighttime. Diagnostic method, calcium to creatinine ratio, and overnight urine testing and collection, and testing show promises of assessing the calcium status. Okay. Here, this is the picture from Nutritional through life cycle with Brown. It can shows that how much the escape of calcium in the urine affected by certain food. Look at the coffee, the caffeine, for example. 6 ounces of regular coffee can lead to escape of 40 milligrams of calcium. So I am usually the girls and boys. The girls has less consumption of calcium than the boys, especially the adolescents. It is around 700 or 600, where they're supposed to take 1,000, 1,300 at the adolescent age. Oh, and they are taking 4 or 5 cups of coffee, which is, around, let us say that 30 O's. So here you can multiply by 5. So 250 escape of the calcium in the urine, okay, from their blood. A clinical case, here we have a case, another case. So, patient, demographic and history. The patient is 68. She is a female, postmenopausal state, hypertension. She is having hypertension, mild chronic kidney disease, bone health concern, symptoms suggest compromised bone health. She is good. We are getting shorter by age. We are getting shorter by 2, sometimes 3 centimeters. Here, in this case, she is getting shorter 2 centimeters by 3 centimeters by 2 years, because the vertebrae get compressed together and the cartilage is dissolved day by day and decay. Impact of the kidney disease. Yes, here the impact of kidney disease in the calcium level and the calcium status is very high because it is not working properly, and this will lead to escape of more calcium, as in other cases sometimes called retention. But here, escape of more calcium in there. Impact of the kidney, so here the kidney is affected. But as we look at the dietary intake of the calcium for this woman is normal, which is around 1,200. What she is suffering from? Symptoms, back pain and height loss, progressive back pain and height reduction, 3 cm over 2 years, often indicates vertebral compression, fractures due to the weakness. Here, with minimal trauma, she fell down, which is not very high, she will be having a fracture because the calcium has been withdrawn from, and when we look at the clear sectional cut of the bone, we can see porous, empty, because all the minerals and especially the calcium, has been taken out. Fragility wrist fracture, fragility fracture occur from minor trauma and reflect compromised bone strength in osteoporosis, bone mineral loss indication. These symptoms suggest significant bone mineral loss, needing evaluation of calcium status and bone health. Here, let's look at laboratory finding. We can see that the serum level looks perfect, nice. It is within the normal range. Low vitamin D level. Vitamin D level is low. Usually the cutoff point is 20. Less than 20 it is deficiency. From 20 to 30 insufficiency. Above 30 sufficient. Elevated parathyroid hormone. The body senses that there is deficiency in the calcium. And when there is a deficiency in the calcium, here the parathyroid level is getting higher because it will organize all the three mechanisms which I told you: increase the absorption from the small intestine, salvation of calcium in the kidney, and resorption of the calcium from the bone. All these are organized, orchestrated by the parathyroid. So because of that, the parathyroid is getting higher and higher. How am misleading serum calcium? Misleading. So it was something 8.5, 9 something, which is in the middle between. I think 2 to 2.6. I cannot really remember the normal range in millimole. So it looks normal. Hormone regulation mechanism. The body regulates the serum calcium tightly through the hormone like parathyroid and the vitamin D. So we can see elevation in the parathyroid, which is another indication. So we have maintaining the normal serum level. Secondary hyperparathyroidism impact. In secondary hyper, what do we mean by secondary hyperparathyroidism? It is the increase in the parathyroidism due to the calcium deficiency. This is what we mean by secondary hyperparathyroidism. Calcium depletion occurs even when the serum calcium remains normal. Diagnostic limitation relying only on the serum calcium obscure the true extent of the calcium deficiency and bone health issue. So it masks, it gives me a very wrong result. It masks the deficiency of the calcium. So I have to depend on something else. So what we need to do, bone mineralization DEXA. It will T-score, so it will give me a good picture. So it gives me a reading of T-score less than minus 2.5. So he is or she is osteoporosis. She is having osteoporosis from the, this is a good indication. Okay, what else? Calcium metabolites. The level of 25 OH, vitamin D, and the parathyroid reflect calcium absorption, efficiency, and hormone regulation. The parathyroid, the hyperparathyroidism, the higher level of parathyroid, this is another indication that there is a problem with the calcium. Urinary calcium excretion, urine test detect excessive calcium loss, because earlier we said that he or she is having a kidney problem, so too much of the calcium is escaping in the urine. So here I can depend on a number of tests. The first, DEXA, the second is the parathyroid, the third one is the urinary calcium. All these three together and the level of the vitamin D, all these four together can give me a solid decision that this person is having iron calcium deficiency, and we need to give him more calcium and we need to give some modification. A clinical significant limitation of the serum calcium, it is the same thing. Conditions like osteoporosis and chronic kidney disease can have depleted poor calcium deposits, normally serum calcium. Multifaceted diagnosis, accurate diagnosis require bone imaging and assessment of the calcium-related hormones and metabolites. Here, limitation of the serum. So the serum calcium is not the correct marker. It's not enough. We have to find alternative bone mineralization, provide a clearer and more reliable assessment, which is considered number one. Okay, vitamin D, also parathyroid hormone. Usually, there is a link between the magnesium and calcium. Can anyone tell me the relation between magnesium and calcium? Means when I am having magnesium deficiency or hypomagnesemia, I am for sure having hypocalcemia. Why? I can say that the parathyroid, it is very important for its function to function normally, having a good or normal level of magnesium. So if I'm having normal level of magnesium, the parathyroid will act perfectly and it will increase in case of the deficiency of the calcium. It will increase and it will adjust all the three mechanisms I talked about. But if it is deficient, the magnesium, so the parathyroid will not act perfectly and all the three mechanisms will not happen. And these three mechanisms, they will not act. Another question, why acute pancreatitis can cause disruption in the calcium status? Acute pancreatitis. Have you heard about the calcium salt? Calcium salt. Okay, when I have a problem with my pancreas, I have free fatty acid due to the pancreatic lipase. So I have free fatty acid, too much of free fatty acid. And also at the same time, that calcium which usually present in the pancreas, because you know, if we remember that the insulin production, it is depend on the calcium and potassium. One channel is closed and the another is open. Okay? So I have too much calcium also. It is not balanced. So I have calcium and I have a free fatty acid. It is like the potassium and the free fatty acid forming the salt. Okay? So they are chelating with each other, and the calcium now is combined with the free fatty acid to form like a normal salt, which we call it the calcium salt. Okay? So I think we have covered everything. So critical thinking always should come in our mind. Problem thinking and solution. Thank you.
Thank you.